I think almost we reached this time, base of the appendix.
Yes, yes. Now I will ligate the base.
Yes, sir.
I will use 3 endo loops.
Ah,
2 at the body side, 1 at the specimen side.
sir.
The specimen side is to avoid the spillage.
Envelope is of chromic catgut?
Vicryl, sir.
Vicryl, okay. Is it made here or is it commercially available?
It is available.
Commercially
if it is not available, you can make it.
Yes.
Only here is that you have to keep the endo loop and then leave the appendix and take it out through the loop. So it is easier to maneuver the appendix.
Yes, sir.
If you can see the endo loop.
Yes, sir. We are able to see.
Yeah. Okay, so the endo loop which is coated vicryl, I am using it and I am tying in the knot at the base. Okay, I will have to hold the knot at the base where I am aiming to tie a knot.
Yes, sir.
And I will just pull out the thread. So it is going to make a knot there.
Automatic and grasp both are automatic.
Dr. Nitin, whether external pressure is being applied on the sac?
Yes, sir. We tried with the external pressure also. It is not
Reducing.
going slowly.
Okay, sir.
Yeah.
Show me.
I think first loop is done.
Yeah.
Yes.
So you have to just make sure that the knot is in place.
Yes, sir.
Okay. See, sir.
I7 mm you have? Okay. ये तो ये हवा लिखने में आ रहा है चलो.
First loop has been cut.
I will try to place the second loop.
Okay.
लिखने होना ना.
The same procedure to be followed.
Reducer
Okay, you have to keep the loop.
Reducer लगा सकते हैं.
Take the appendix through the loop. It is easier to
इसके ऊपर लगा सकते
take the appendix rather than maneuvering the endo loop.
Look.
हैं. Nice.
Okay. Once I lift the appendix, the assistant job to hold the appendix, then I will tie a second knot just proximal or just distal to the first one. So I am aiming to tie a knot here.
You have put, Dr. Nitin, you have put the fourth port or is it the third one?
No, sir. It is a second port only. We change it to 7 mm.
Okay.
Yeah. Clean the camera.
Sir, what is that?
Because the ligature which we are using, it was too tight to move through the 5 mm.
Okay.
I generally make sure that my two knots are not on the same place. They are at least 5 mm apart.
Yes. Make upside down now.
Yes.
Yeah. Very good.
Oh.
I know. Don't worry. It will take some time. Table up, please.
Now my two endo loops are in place. I am going to put third one at the
Left side.
specimen side.
Bas, enough. Bit. Left. Yes. Enough. Yes. Foil grasp.
So third knot is also put now. Third loop is in place.
Ah. I'm going to keep this
There is an option,
thread
sir.
long
Yes.
so that I can hold that
Leave it,
same
leave it.
thread and
Is it leaking?
take out the appendix through the optiport.
क्या हुआ?
Is it an option to cut only the appendix and take out with the loop only, with the same thread?
We can take out with the same thread, but not through the same port.
Okay.
I will take it through the optiport.
Okay. Fine.
Now I am cutting this appendix.
Okay, sir.
Give me better end.
Yes, correct. Keep it like this. Yeah.
Sorry,
Dr. Nitin has almost reduced the contents. Only few remnant addition, metal additions are there. I think by and large the transverse collar has come down.
बस इधर मेरे लिए ऐसा नहीं है अंदर डालना
It might have come down.
इस तरफ से देखो.
Dr. Nitin, could you make out the previous surgery's mesh? Is it somewhere near seen?
So suture can be seen here. Some suture,
Mesh?
but not mesh.
Okay.
We'll see whether after complete reduction whether I can see. There are some dense adhesion. So I am going bit slow.
The appendix is cut, now ready to be extracted to the 10 mm port.
हाँ ये ग्रास पर
Yes. Still this loop is ये loop है ना ये जरा आएगा धीरे धीरे आएगा. Wait. So in such cases patience is the key, I think.
Sir. Still transverse collar is yet to come down fully.
Please clean the camera.
you have to make
Dr. Sudatta, are you ready to take out the appendix?
yes sir, I will take it through the optiport.
Up to port is 10 mm.
Yes sir, yes optiport is 10.
Okay, yeah, better. See, this is badly dense here.
Any tips to the Dr.
You will
Nitin
have to
by the
make them
panelists?
straight. No, straight in the sense with this suprapubic foot.
Yes. अरे जॉइंट में चिपका है. शॉर्ट जॉ वाला आहे का कुठला?
No, who is holding the camera to Dr. Nitin? He is doing a good job.
Aftab.
Uh,
Dr. Aftab is
Aftab.
my
good.
eye.
Good.
Yes.
You have to make it straight.
That is the beauty of a 30-degree camera.
Sir.
You can see the any corner of the abdomen
Yes, sir.
with a good assistant, and I am
Now you have to remove the port.
lucky to have Aftab today.
Artery, wait. You have to open and then okay, sure. Wait.
Dr. Nitin, you are using bipolar cartridge?
Ligature,
Ligature.
golden ligature I am using.
Okay.
Yeah.
Keep the specimen here, we will show you. Keep it here.
I think appendix is out, sir.
मुझे ना ये
The appendectomy done,
हाँ,
looks like, it is
I
complete.
think it deserves an applause from the audience. Dr. Sudhir, I can hear the applause from the audience.
Thank you, sir.
Thanks.
The appendix is out, but I would like to see the base and burn the mucosa
Okay.
so that it will not have any secretions.
Which is better to burn or with, just treat with the betadine and come out?
I would like to burn it. You can use the betadine also.
Okay.
Ah. Yes.
Just need to observe before taking my decision. I am just checking.
Yes, sir. Nice. Stump is good.
Before applying the bipolar, I just want to check the bowel loop because
I am using monopolar quadri here.
last
Yes,
knuckle.
yes, sir.
Yeah, you can see here. Okay.
Hook,
Here it.
Hook. Just coagulating with the hook.
Am I audible? Okay. ठीक है जान लो.
Who is speaking?
Dr. Nitin here. Am I audible?
Yes, sir. You are audible.
Yeah. My screen is visible there.
Yes, sir.
Yeah. So before
no
applying the ligature, I am just checking the last knuckle of bowel loop here.
Yes, sir.
You can see here the bowel is.
We should always have a look for
I don't think there
Baker's
is bowel. This
diverticulum.
is the bowel.
Yes,
This is
sir.
the
Bowel loop.
bowel, so I can
Bowel
safely apply
Yes,
the
sir.
But the
ligature here.
patient had underwent CT scan. So
Okay.
CT did not pick up any Baker's diverticulum. So
Yes,
I would
sir.
like to close this case.
Okay.
There is
No-
no Baker's as suggested on CT scan.
Okay. No bowel walk.
No bowel. Yes.
Okay.
If you are doing it for acute appendicitis only on the basis of clinical findings and ultrasonography, then it is mandatory to do a bowel walk so that
Okay.
you should not miss any Baker's diverticulum.
Okay. The patient position is you have taken a right up?
No sir, head low and yes sir, head low and right up.
Head low and right up. Okay.
Yes.
Okay, sir. Thank you, Dr. Sudatta. I think procedure is over.
You can see the specimen of the appendix.
Just external view has to be shown, sir. We are seeing the internal view now.
Sir, just a second.
Yeah. I would like to thank organizing committee and Dr. Harshvardhan for inviting me as a faculty for this live workshop. I would also like to thank Dr. Satish Daruk sir for his continuous support and guidance, and the wonderful anesthesia team for.
Sir, could you please show us the specimen just once?
Yes, yes.
Because we couldn't see it before.
Yes, sir.
Yeah.
Closer
We can
view.
Yeah, we can visualize it.
Okay. It is nicely, hardly there is any mesoappendix left on the,
Number one, relock keep ready.
Appendix.
Needle holder keep ready.
okay, sir.
Thank you sir. Thank you so much.
I am just checking last bit whether there is any oozing or bleeder and bowel also. So you can see this was the transverse colon was going inside, and this is the probably just mesentery part, some mesentery. Yeah. Okay. ठीक.
I think the contents of the hernia has been reduced.
Yes, yes, yes.
A very good job, huh?
Yes, sir.
It was smooth sailing.
Go in this defect, just showing whether we can see the mesh. I can feel hard paper, so I can't see, sir, through the,
Okay.
yeah. So while suturing one of bite, I will try to take this sac.
Okay.
Yeah.
In the
It doesn't appear to be a mesh.
mesh, difficult because I don't know whether there is any thin layer of.
Yeah, sir. Can you see the mesh, previous mesh? Make a schedule.
Difficult. Just, are you seeing, sir?
Wait. Yes, yes, I have seen on one of the corner.
It has gone down, I believe. It has migrated downwards.
Is this a mesh or adhesions? There's no mesh.
Yes, sir.
There
Can
may
you
be-
see?
There may be a layer of
This is
fat
mesh,
over
sir.
that.
Part of
And-
mesh.
Sir.
You appreciate, sir?
We have difficulty in appreciating here.
Okay.
Maybe in some patches it may be there.
Yeah.
Other
It's
patches
patches only.
Ah,
It's not clear.
Probably it is covered by the fat in other places.
Upside down.
Are we able to close the defects on now? With the
With the number one bar suture, sir.
okay.
Yeah. Sure.
Finalists have any other opinion? Sir, you have any,
Dharmeshwar.
any other
Very
opinion?
good job done
Sir. Your choice of closing the defect?
for this. I-form, yes, I-form plus.
Okay.
Remove the camera.
What is the material used for closing the defect?
Barb suture,
Bob, okay.
1 number.
Okay. Some people do use loops.
Sometimes extracorporeal.
Ah.
Left hand Maryland. Maryland left. I have introduced the number one bar suture
Yes, sir, we can
from the
see.
Covidon.
What material it is, sir? Material?
What, sir?
Material?
Stable down.
That's what it looks like.
Camera, please show me. Yeah, you can reduce a bit. Yes, upside down, please. Camera. Disposable rubber.
You can see there is a small loop at the end, the tip of the bob suture. He will take through that. It reduces the efforts required in the intracorporeal suturing.
Brother, can you jelly लावा थोड़ी? अटकता है.
You can see both internal view and external view, endo view and outside view, how he is operating. The ports also you can appreciate.
मेरा मैन प्रेशर कितना कम किया रे? प्रेशर क्यों गया? नीमो क्यों गया? पेशेंट आउट नहीं ना? प्रेशर
Sir, what is the pressure now during the suturing?
Sir 10.
10 you are keeping, okay.
आउट है ओके.
Even during fixing the mesh also you keep pressure at 10 or it is still reduce further?
Sir, it depends upon if it is too much tension, then I reduce it to 8 also.
Okay, sir.
Yeah.
चली लगा तो
पता नहीं लेके आता था पहले सुचेरिंग के लिए ना.
Taking sutures on the roof is difficult task. Sir is doing very well. Dhanithin is doing it well. He's trying to take him one stitch through the mesh, a sac, so that the sac is reduced.
So you are taking the stitches through this mesh also, previous. I'm Dr. Nikhil Gowde.
Yes, sir.
I'm also a
So
senior.
basically trying to take a sac or mesh previous, so that there would not be much dead space for seroma, and also patient will give the feel of, otherwise there will be swelling for some time due to seroma. Let me see, but it is densely added to the previous mesh.
Whether the external pressure will help, sir, in taking the stitch?
Yeah. Wait, steady. Get it.
needle holder different.
Yeah, I know. I'm not used to this.
So is it necessary to take stitch from the mesh, or we can only close the peritoneum?
Not from the mesh, it is basically through the
fibers.
sac
Uh-huh.
to avoid the dead space so
Okay.
that there would be post-op seroma or patient may not feel sometime.
Okay.
So to avoid the dead space, sir, that's it.
Yes, sir. Okay, sir.
ये नहीं दवा सर यार मेरे को पता नहीं था ये मैंने ले गया था ये भी कार्ड टूटेगा नहीं नहीं या, ठीक है लिखो निडल लिखने को तो अच्छे clip gloves, mesh and decorating.
Only one suture is enough.
He is completing that suturing is a defect. Probably last stitch is being taken.
I'm locking probably the last stitch
Yes,
so
sir.
that it get a double. Okay, sir.
Yes, sir.
I will take one more.
Okay.
Getting loosened.
It is becoming a bit loose.
Yeah. So if the stitch is too much superficial, then it get loose.
Yes.
So you have to go through the fascia.
Actually, I was about to ask what how much distance you keep from the defect? 0.5 centimeters or
How much?
distance from the defect edge? Edge of the defect?
It's standard usually 1 centimeter, sir. 1 centimeter usually.
Okay.
Holding needle is a very important. See, now it
We
has
understand
skipped,
the
so
difference.
I could not take the stitch.
And we understand the difficulty in doing the rooftop suture.
Yeah. Upside down. Wait. Wait. Yeah. This upside down proper angle, that is very important.
Yes.
Sorry. Okay, sir. Just show the defect. Okay, sir. It is-
Yes.
You appreciate it is closed?
Well done, sir.
Yes.
Yeah. Thank you.
Very well done.
Caesar. रोका दे sir. चलो 15 mesh below chain. Okay.
So this is new port which has been placed.
So we are using the Paratex 15 centimeter mesh from the Covidon. So it has got pre-placed two suture, which is, and it has got one layer which is a, this is a visceral layer, this is a parietal layer.
Okay, sir. You are going to use the
Wait first.
loops or you are going to cut them off?
No sir, suture.
No, that switches are, you are going to use them
I am going
inside.
to use it for fixation.
Okay, sir, for fixation.
Yeah.
Any extra sutures we have to take on the other corners or only these?
Yeah, initially you should take, I think. Otherwise it is not needed.
Okay, sir.
You are transfixed to the abdominal wall or you
Yes, yes, I will transfer to the abdomen wall,
okay.
two suture. Grasper, give me ball, yes. No. So this roll mesh I am going to put to the 12 mm. Chalo, come in. One more ball as per. Come in quickly.
This mesh is of which company, sir?
Covidon.
Covidon. Any representative is there?
Yes, yes. Ashwin is there.
What are the cost of supply to the government organizations?
Sir, it depends upon institute to institute. By monthly, we give at nearly 20 to 23,000.
Hello? We are not able to hear you. Be loud.
Sir, he is saying it depends upon the
Quantity.
quantity, but
Okay,
it's
fine.
around 20, 22 he is saying for government sector.
Okay, institutional price.
Yeah.
Okay.
Show me medial edge. So this is upper suture and this is lower suture. I will going to take it down. Chalo. Suture person.
Some people take out both these stitches. They take out one stitch at the center and fix it at the center, then just tack all around.
Yes, sir. Yes, sir.
So do you feel that it is adequate distance? Or you have to take the, do you think there is adequate distance or you have to take down that falciparum ligament to some extent?
Falciparum bit down. Yeah.
You
I
need
just
to
notice
take
it now.
You will just have to
Better
take
to
it
take
out.
3-4 centimeter. Yeah.
Usually, how far we have to go beyond the margins so that the mesh should be very taut?
I don't think beyond 1 or 2 centimeter, 2 centimeter maximum, sir.
Okay, sir.
So while taking the falciform, we need to be very careful because it can bleed.
Yes, sir.
I think enough now. I'm just trying to hemostasis, achieve hemostasis here. Okay.
Yes, sir.
Yeah. Enough, sir? You agree?
Yes, sir.
So falciform I took is that. Suture person. So whatever mark I have done in the deflated abdomen is 15 centimeters. So I will go around 1 to 2 centimeters beyond it.
Okay, sir.
Mosquito. The bottom. You want to go up? Just a minute. Pitch.
Sir, in what situations you decide not to do plus?
So I think IPOM per se is absolute now. Nobody does it, and you should not do. If you don't able to close the defect, don't do laparoscopy. Nowadays it is
Okay, sir.
because the recurrence it is proven now. It is very high if you don't close it. Just putting the mesh, or you can do the hybrid technique if you are not well versed with the suturing, or you can try the transfacial suture. Take mesh down. Other one.
Dr. Nitin has already marked the mesh size out from outside so that he can easily take the sutures,
Yes, yes, yes. I had
transfixation
marked
sutures.
it, keeping the defect in the center.
Yes, sir. And the transfixation is being done.
Tracker. So I am using the Covidon absorbable tracker, Absorbotac.
Okay.
I always use absorbable because if sometime by mistakenly we hit some small nerve and in non-absorbable tacker there is the patient get a pain for prolonged time.
Okay.
This is the outer layer I am trying. Counter pressure with the opposite hand is very important.
So you have reduced the abdominal pressure while,
Not much. You can reduce bit.
Now it is 12 or 10, sir?
12, 12. You
Okay.
can reduce bit. 10, 10 कर दिया. 10, 10 कर. Too many.
Nicely fixing with all around. Now he's taking the inner layer.
Do it.
I'll take one, you'll take one more circle, this one, sir?
Yes,
The inner
yes.
circle?
Nitin sir,
Yes, sir.
sir, one question from my side. Your choice of any takers.
I use absorbable tacker.
So,
Non-absorbable I said because if I hit some nerve, the pain is prolonged in my experience.
okay, and any choice of mesh, or you are happy with what you have got right now?
Yeah, this is Paratex is good. I am
Right.
using Paratex only. COVID.
Okay, sir. Sir, any particular hernia case which you have done wherein you have used the tackers, and after certain days or on the post-op day 1, the patient is presenting with signs of obstruction.
Obstruction on post-op day 1, no, but few patients present with a severe pain. In that case, sometime we may have to give a block with the absolute alcohol also sometime.
Yes, so in our hospital at Baikala, we are generally giving the tap block after these cases of IPOM plus that we are doing over here. So yes, your point is well taken that they will be having some pain, but in between there were certain cases which had some sort of paralytic ILES. Patient had to be put on a Riles tube, and after some 48 hours the patient settles. Any opinions from the August gathering?
More tracker, more pain.
Post-op
pain, I am telling.
one obstruction is rare. You may get pain, but obstruction will be rare unless your mesh is not properly placed. If you don't put those stackers around, the gaps, the bowel can get adherent because that is where the protective coating is not there. So if you keep the outer ring gaps between two tackers, that is where the intestine can go in. That can cause problem, but not on first day. Third or fourth day, I have seen people having it.
Okay,
So,
thank you, sir.
Kanak Rai sir, do you agree? Is it okay?
Okay, sir. Well done.
So the paralytic ileus on day one could be because of the carbon dioxide irritation of the peritoneum. That sometimes happens. I have seen it 3-4 times. And after starting the patient on orals, suddenly the patient goes into an obstruction
First
like
24,
symptom.
48 hours, they need
So all you
multi-prong.
need to do is just put in a rice tube and conserve, keep it for a day or so, and it settles down. Usually it's not a problem.
Right. First 24 to 48 hours, they need a very good analgesia, basically multi-prong analgesia. The tacker pain is quite cumbersome.
Sir, how many tackers are there and how many are remaining?
Still 9 left out of 30. 21 I have used.
21 you have used till now. Okay.
Any question from the audience, sir?
Audience, you want to ask any questions? Panelists, opinion from panelists?
Very good job done.
Opinion, criticism are welcome. Chalo, thank you very much.
Thank you very much, sir.
Thank you.
Okay. We can hear the applause from the audience.
सक्शन है सक्शन सक्शन है क्या सक्शन नहीं लगा है ना ठीक है निकल गए तो नीमो का पेन बहुत डेंजरस रहता है इरिटेटेड आई फ्रॉम लूज करेगा तो
Sir, I'd like to call Dr. Kanakraya to just give a token of appreciation from Baba Saheb Ambedkar Memorial Hospital on behalf of everyone. To the panelists, Dr. Sajit Pagada and Dr. Dharmshri.
ये लाइट बंद कर दो लाइट गैस ऑफ कर दो
लीन करो थोड़ा बेटर और मेरे को फॉलोअप मैसेज करना चाहिए स्पेशली ओके आफ्टर 12 आवर 24 आवर
Thank you so much.
चलो थैंक यू चलो स्वाति थैंक यू
We'll be soon having the inaugural function followed by lunch. So let's just wait.
I would like to say is that after the procedure is done, putting a good compression dressing on the area of the hernia prevents seroma formation.
Yes, that's why I took the stitch from inside, sir.
Yeah.
So that the dead space is minimum, but still we can put a pressure from outside for first 24-48 hours is very important.
Thank you.
Thank you.
So shortly we are starting with our inaugural function. We should be very, very short and very, very crisp about it. नहीं एक तो नरेश रॉस है और देवाशीष दास आकाश
सिस्टर कुठे गेल्या? आकाश होता है बा सिस्टर. त्यांना दिलं का? एक एक करून सगळ्यांना दिलं. कनकराज सरांचं आता जे पॅनल झालं ते दिलं का? कधी दिलं? आताच दिलं. हाताने दिलं का? आता नाहीच नाही का? म्हणजे सिस्टम होत्या सिस्टमने पास केलं कनकराज सरांना सरांना पॅनल दिलं दिलं. चेअर्स लावणार शेवटी. हां देखील नो नो नाही फॉर द सिस्टर जरा लवकर घेऊन घ्या. So till the time my supporting staff is actually arranging the things, I would like to tell the August gathering that our Honorable Principal Chief Medical Director is actually busy with a Chairman Railway Board video conferencing, and that is why she has sent her blessings for the program. She would be physically absent over here, but her blessings for this program are completely with us. Without spending a lot of time, I would request our medical director, Dr. Sushma Matta Madam, our chief specialist, Dr. Jamuna Madam, Chief Health Director, Dr. Kanakaraya Sir, ex-PCMD and Chief Consultant Surgery, Dr. Meera Arora Madam, Naresh Rao Sir, Debashish Das Sir, to please join in ahead for lighting of the lamp. सर का आधार का कुछ है, so he is not able to come. Shetty sir is in Vashi, he will take some time, he is saying. या कुंदेंदु तुषारहार धवला या शुभ्रवस्त्रामृता या वीणावरदण्डमण्डितकरा या श्वेतपद्मासना या ब्रह्माश्रुतशङ्कर प्रभृतिभिर्देवैः सदा वन्दिता. Thank you. May I invite Medical Director Dr. Sushma Matta Madam to please be on the dais. CHD Dr. Kanakaraya Sir to please be on the dais. Dr. Jamuna Madam Chief Specialist to be on the dais. Dr. Meera Arora Madam Chief Specialist to be on the dais. Unfortunately, Shishir Setti Sir and Dharab Sir are not here, but they have asked Naresh Rao Sir and Debashish Das Sir to look after the proceedings. So I would invite ex-Vice President Dr. Naresh Rao Sir to please be seated, and Debashish Das Sir to also be please seated.
It gives me immense pride and pleasure when I announce that a live operative workshop is to be taken at our Bharat Ratna Dr. Babasaheb Ambedkar Memorial Hospital at Baikala. We are a 366 bedded hospital with a legacy of over more than 60 years for this hospital. The Department of Surgery has started the seats in DNB in general surgery since 2001, and in 2026 we would be certainly finishing with the 25 years of our general surgery. So as we have it, we would start with the welcome of the guest. As Principal Chief Medical Director is not there, I would like Mate Madam to please stand up and accept our welcome. Hello.
Dr. S. Kanakaria, sir. CHD, sir.
ठीक है. Ex-President of MSS, Dr. Naresh Rao, sir. Dr. Debashish Das, sir. CHD, sir, Dr. Kanakrai. Jamna madam, na? Ex-PCMD, Dr. Meera Arora, ma'am. And our very own Jamna madam. I would now request Kanakrai sir to please give a brief of this live operative workshop.
Good afternoon all. Our PCMD madam could not join because yesterday she had gone for inspection from Balasha to Nagpur. She came quite late in the morning, followed by with that one more scientific program going on in CSMT, as well as one safety meeting going on with CRB, Chairman Railway Board. So she could not make up. She has conveyed her best wishes, and I welcome all the delegates and my colleague surgeons who have joined here. They have come all the way from entire Mumbai. Basically, we are an industrial organization. Our primary function was to take care of our employees, their fitness and their sickness and issue 6 fit certificates. Secondarily, we'll take care of our railway family, entire railway family. From that, we have moved every possible ways to become well known in the healthcare sector. And in this journey, many achievements have been done for the first time in India by the railways faculty. Like, we are the first to do open heart surgery in Perambur Railway Hospital. That was an achievement. And as you know, the gastroenterology in Western Railway, plastic surgery in Garden Reach, and our own digital dentistry in hospital, in our own Baikal hospital. We are about 125 hospitals chain in Indian Railways, and around 30 hospitals are recognized for DNB courses. In Central Railway, we have 11 hospitals with 1,164 beds, and 5 sub-divisional hospitals, 5 divisional hospitals, and this central hospital at Baikala with 366 beds, which is going to be increased further. And in addition to all these facilities being given, soon we are going to have medical college in our railway setups, and this hospital will become a postgraduate institute. We will be awarding MD and MS degrees soon. From doing initial medical examination and periodic medical examinations, attending railway accidents, we do attend railway conferences and specialty conferences. We have moved to large distance, and we thank the Mumbai Surgical Society for joining us and helping us in developing our own setup and system. Being a member of this Mumbai Surgical Society as well as Chief Health Director, I thank them. And we have tried to, as you have seen, we have tried to showcase what is done routinely in our hospital and taken care of the operative team. Most of them are surgical surgeons from railways and our own consultants who come on case-to-case basis. You have seen that. I basically joined railways in 1993 after completing my MS General Surgery from Ghati, Aurangabad, Maharashtra. That I joined in 1990. From the that is Ghati is Government Hospital and Training Institute in Aurangabad. It is a government hospital for a long time. I joined that in 1990. And we have come long way, and I think many of the procedures now standardization is going on, and I think all the surgeries what is being done are being done in a standardized steps, reducing the complications. And as you know, Dr. Ashwardhan has done his MS from Mumbai. I think he knows most of the faculties in Mumbai, and I think he will take more initiative to see that more and more live workshops are done in this hospital so that all of us can have more exposure and experience. Thank you.
Thank you, sir. I would now request Debashish Dash, sir. Okay. So I would now request ex-president Dr. Naresh Rao, sir, to please guide us.
All the three ladies, dignitaries, and people who have taken time out to be present here. It's indeed a pleasure and a privilege to be in front of you. Mumbai Surgical Society saw the light of the day in 2014 on one auspicious day, and since then we have grown from strength to strength. We are now 470 plus surgeons across Greater Mumbai, and I have been associated with it right from the beginning. I am very happy that Dr. Harshavardhan Shirsat and Dr. Kanakarai took this initiative of planning this live operative workshop. I have not till date in the past decade missed a single CME or a workshop of Mumbai Surgical Society. So it's like I've become a permanent fixture here, and it's always been a pleasure. And I'm really happy to see the setup, and especially meet Dr. Arora, who is from my hometown Nagpur, and see all the good work that is being done here at the Railway Hospital. I hope you enjoy the rest of the operative workshop, and we'll meet again for lunch. Thank you.
Thank you, sir. Even Mate madam is from Nagpur. I am from Nagpur. So the list is unending. So now I would call upon Medical Director Dr. Sushma Mate madam to please share her views on this auspicious occasion.
Good afternoon all the dignitaries on the dais. Our respected PCMD madam, she could not make it today here, but her blessings and guidance is always there with us. We have our CHD here, who is surgeon also, Dr. Kanakarai. Then we have our Dr. Meera Arora ma'am. She was here as MD and then as PCMD, and madam is again here with us. We are so happy to have her here. We have Dr. Jamuna Kanakarai madam. She is again a gynecologist. So you will see that surgeons are there and they are leading from the front. So all these three are my administrators from our Central Railway, and they are leading from front and they are surgeons. Respected Dr. Naresh Rao sir and Dr. Debashish Das sir, all the surgeons who are present here from Central Railway, from Western Railway, and from Mumbai, various parts of Mumbai, they have come here. As I stand before you as the medical director of this prestigious institute, I feel very proud and privileged. This hospital, as Dr. Harshvardhan was telling you, has a very historic place, you know. It was initially been a Elphiston College, before that Elphiston School, then college, then Dr. B.R. Ambedkar himself, he studied in this school, then he taught here in this college. Then this place was converted into VJTI, Victoria Jubilee Technical Institute. Some classes of engineering were held here. Now we call that institute as Veer Jijamata Technical Institute. Then it was handed over to Railways for its headquarter hospital. So the history of this heritage building is very long and very prestigious. We are very proud, you know, to have not only the building. When we talk of the institute, the human resources matters the most. And here we have, in this 366 bedded hospital, all specialities of surgery. And there are 8 DNB programs running in this hospital, and 5 of them are in surgical branches, say like general surgery, ENT, ophthalm, then gynecology and anesthesia, and orthopedic, yes, orthopedic, and of course medicine. I'm a physician, but you will see that I have put the medicine at the last to take care of everything. So jokes apart, I'll tell you that the hospital, if you look at the annual data of surgeries of my hospital, it is more than 5,000 surgeries we perform in a year. And these surgeries are not the routine surgeries, you know. Apart from routine surgeries, our ortho surgeons, they are performing, of course, total hip replacement, total knee replacement, And spine surgeries, advanced spine surgeries, we have in fact a fellowship program of 1 month, not only of Indian orthosurgeons of India, but abroad. People from abroad have come here for 1 month fellowship and done the fellowship in spine surgery. Then we have the ENT surgeon who performs the cochlear implant surgeries. And even we have the retinal specialist who is performing all advanced retinal surgeries. We have the surgeries being performed here, or oncosurgeries, urosurgeries, plastic surgeries, even neurosurgeries. So I'm very proud to be a medical director of this institute where surgeons are so high performing. In fact, my surgeons, if I don't pull them out of OT, they would like to eat there and sleep there also. Now this famous dialogue is from Dr. Meera Arora. I'm just telling it to you. So the surgeons are that much dedicated here. And why I am telling all this about my hospital to you, because still we need surgeons and young surgeons are there. I want them, if possible, join railways. Railways give you good academic environment that you must be witnessing since morning. Mumbai Surgical Society has thought of doing this live workshop here. I am thankful to them. And they have shown their trust and responsibility to our hospital, our surgical team. So I am very happy for that. And I hope that you learn something from here which you can practice. And when the crowd is small, it is better to interact. So I think you should be asking more questions, more interaction should be there, and make this conference very fruitful for you. I thank you all for this event. Thank you.
Thank you, madam. Madam, I would not let you sit down because we are having our distinguished surgeons who have been here since morning with us and who have operated upon cases. So I would request you to kindly felicitate Dr. Hemant Jain, sir. He is yet to operate. He will be soon showing us one of the most wonderful fundoplications that we are going to see after the post-lunch session. Dr. Hemant Jain, sir, is MCH in GI surgery, and he is operating at many places in Mumbai. And he is one of our seniors from Sion Hospital as well. Dr. Hemant Jain, sir, please. Thank you, sir. I know everybody is just wanting and waiting to see you perform the fundoplication. We recently had a very wonderful presentation of a large intestine which was inside the hernial sac, multiple adhesions, and very beautifully done by our own Dr. Nitin Borle, sir. He is additional professor of surgery at Nair Hospital and one of my beloved seniors from Sion Hospital. I am happy, sir, you are there, and the job was wonderfully done. Thank you. And last but not the least, Dr. Sudatta Vagmare. He is not only a general surgeon by his heart, but a laparoscopic surgeon to the core, and he has finished his diabetic foot diploma under Dr. Arun Bal. He is a help to me at any hour in the day, any hour in the night. Thank you, Sudat. Thank you for being here. And I know everybody is hungry, but there is a last thing, that is the vote of the thanks, which I will be proposing very shortly. So as the coordinator of the program, and to conclude this August gathering, I wish to thank our PCMD in her absence. She had conveyed her blessings to us through CHD sir. Her support goes ahead for this program and for all such programs. When I went to her for permission, she immediately said yes. And when the topmost boss says yes, the things starts flowing down very, very easily. And if I talk about MD madam, she has already put her heart across to you. that madam, I want to do this, and madam, without your permissions and your guidance, the completeness was next to impossible. Madam gave me suggestions starting from पेशंट्स बरोबर घेतले की नाही, त्यांचा ॲनेस्थेशिया फिटनेस काही राहिला आहे का, कोणाचं BP वाढलं असेल तर सांग पटकन कोणाला तरी. Till the time we are making the OT list, and till yesterday in the evening we had a small chat about what I am supposed to do. So madam, whatever I thank you, it will be again less. I thank you from the bottom of my heart. I personally thank our ex-PCMD Dr. Meera Arora for making me come from Nagpur and catapult into what I am today. Madam, you must have had seen something in me, and that something in me is bowing down to you with utmost reverence and gratitude. Everyone who belongs to this railways and present in this auditorium knows about your dedication for the converting this institute into what it stands today. Your last minute nudges for making things in a certain way have helped a lot of things in every one of us present here. Thanks ma'am, I know there is no word to thank you enough. Dr. Kanakraya sir, being a part of the department of the surgery and also handling the helm of Central Railway at the headquarters, I know he is bogged down by 6 different divisions and 6 different type of calls, but the surgeon in him doesn't say that you don't have to die. So he will usually come to us, he will operate. And sir, thank you for blessing us with your presence and with your activities, because it not only helps me, it helps the patients a lot. Jamna madam, thank you for supporting outrightly for this academic extravaganza. Madam, when you had come from SWR here, you had called upon people who wish and will to get their publications done to approach you, and that really speaks volumes about your selfless attitudes towards academics and medicine as a whole. I thank you for being the part of this live operative workshop and to make me realize the true potential within me and guide me for the same. I thank the whole team of MSS, starting from Shishir sir, not present here, but his blessings are there. Dr. Naresh Rao sir, as he says that he is a permanent fixture with the MSS programs. Dr. Sen sir, Dr. Dharab sir, who was present in the morning, and past president Dr. Niranjan Agrawal sir. It's a special feeling for me to do this event in front of my PG guide, who is apparently right now, I mean, he is blocked up with some form or something. But he is mentor for me for life, Dr. Satish Dharab sir. Sir, thanks for making me what I am today, what I am standing over here. My heart leaves my body to touch your feet. And until the time I am alive, this gratitude is all only going to increase. Thanks for instilling the ideals of simplicity and gratitude that helps me achieve more and more in my life and makes me what I am today. Without you and team MSS, I would not have been realized this type of event and would not have been possible with the idea which was shared by Dr. Niranjan Agrawal sir, shaped by Naresh Rao sir, and blessed by Shishir sir. I just hope that the constellations of the universe would allude in such a manner that the MSS Con should also happen at this very place. Well, with the permission of my higher ups and good wishes from my colleagues, I will be bidding for next year's conference for sure. Thanks MMC, who has graciously given us the 2 credit points for the academic extravaganza. I thank Dr. Borkar sir, he is not here, for being the observer of this event, but probably he will join us soon. I thank my anesthetist, well led by Dr. Swati, Dr. Yatish, Dr. Preeti, and a whole lot of my residents. I call them my residents because they are present at my call as well, who handled the show so far with utmost professionalism and grace, and you and my surgeons are a testimony to that. The hassle-free case induction and extubation would surely make other surgeons envious of me for having such a great team of dedicated anesthetists around me. I actually want a huge round of applause for my anesthetist. I thank Gynec department, Dr. Beena madam, Dr. Jamna madam, Ashok Kumar sir, and Nirmala for giving us their OT for today and the lab set also for today's workshop. Without my OT staff, I would not have been standing over here on a Saturday on a half day working you with a full day live operative workshop. Sister Marsa, all cheers to you, and truckloads of accolades for management and man-to-man matching for making this event a savoring success. Similarly, my post-operative ward Lizzie sister in charge and her team for taking the patient swiftly from the OT to the post-operative wing. I thank the major sponsors for this event, MS Medtronic India, who agreed on one call for sponsoring the whole event, starting for making the calls, live transmission, to catering, to folder making, to mementos. You have helped me a lot. Thanks Kiran, Akshay, Ashwin, Nishi for leading from the front and answering my distress call. I thank the whole team of Medtronic India and request for closer participation for future programs as well. I thank the SNT Electrical Civil Engineering Department for making this program a huge success. I also thank my wonderful assistant nursing officers who are sitting back. They are sitting back, but I am standing front because of them, because of our sisters who can actually make out an event management company, as what Dr. Meera madam famously says. So Satam sister and Purohit sister, thanks a lot for the Rangoli as well. Thank you Abhishek, Rajiv and all my staff of the health section who helped me get the premises clean, spick and span, and that too at one simple word of "Mujhe ye saaf chahiye." Your contribution today not only speaks about the love that we share, but also the camaraderie that we have. May they stay forever. Thanks to the team of the senior doctors and colleagues from Baikla for helping me get things organized in a certain way to make them look elegant. I thank ex-CPRO Shri Shivaji Sutar sir for helping me getting those beautiful mementos which are there. I had promised Naresh Rao sir that I will be giving the mementos which will not be kept aside, but they will be somewhere in your beautiful galleries, and I hope sir I have proven myself right. The National Rail Museum to NDLS station, this route was helped by our ex-CPRO Shri Shivaji Sutar sir by appointing not only a parcel but giving a dedicated vehicle for the transport. In the same breath, I thank Dr. Swapnil Neela, the present CPRO CR, for helping me with the photography of this event and thus making it a strong memory for all of us. I similarly thank the good offices of Shri Suresh Pakhre sir for allowing us to use the space for parking at the Nirmal Park for the delegates of the program. Without the patients, no program can happen. And as many thanks to them as possible, they will always be less. So having trust with us, thanks to all the patients. And last but not the least, my own residents, Dr. Manju, Aftab, Akash, Abhishek, Deepak, my whole lot of interns who have come to me on my one call, and all you lovely delegates. You make me believe that I can achieve better and bigger things in life. I owe a lot to you guys, and we shall celebrate not for this event, but for a lifetime of companionship that we are going to share. Thanks for being there for me, even for the harshest of the words that I have said, and for the loveliest of the moment that we have shared. You all are my Horcruxes and shall be like forever. That was a huge long vote of thanks and I don't want to be much in between the lunch with all of us. With the permission of the chair, I would request all of you to join us for the lunch. And the lunch will be short one because shortly we will be starting with the fundoplication surgery. Thank you. Sir, please join us. Sir, photograph.
Take it right now. Yes. Take the anesthetic.
Swati, Yatish, Preeti, आपण वर उभं राहूया. नहीं, आप लोग नीचे बैठ जाइए ना, मैम. We will stand here.
हाँ, ठीक है. हाँ, ये ठीक है.
पवन आ जाओ. सुजीत, come. आफ्ताब, मंजू,
सब लोग आ जाइए.
आकाश.
सगळे जण या, सगळे जण या.
इंटर्न्स चलो आ जाओ. तू पण ये दर्शन.
अरे वाह.
The main person has to
Yes, yes. Sir, yes. Yes. Don't look puzzled. Take a good photograph. Yeah.
Thank you. Madam, sir, answer moment.
Oh, yes, yes, yes.
Sorry, I got delayed.
Thank God you came.
I request MD Madam to please felicitate Dr. Dharab sir, who is not only the secretary for the MSS but also the academic dean of Nair and the professor and head of surgery at Department of Surgery, Nair Hospital, Mumbai. Sir was my guide and mentor for life, and I owe everything what I am today to him. अरे अरे बाद में Thank you, sir.
हाथ में दिखा बीच में तो पता है मैं फोन को ऐसे लगा के खड़ा हूँ से लाइव में रहते तो गाली अरे सर 2-3 साल में तो आपको उधर रहना है क्या सर आपको उनको अरे एंकरिंग क्या सर आपका कितना छोटा सोच है मैं बोल रहा हूँ उनको बनोगे आप एंकरिंग सोच रहे हो
check, check. Hey. Check, check, one. Hey, check, one, two. Hey, hey. Check, one. Hey, hey. Okay? Check, check, one, two. Hey, hey. Check, check, one, two. Hey, hey. Check, check, check. Check, one. Hey, check, one, two. Check, one, two. Check, one, two.
Hello. 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 Hello.
तो 1 मध्ये आहे की 2 मध्ये? 1चा कॅमेरा बंद आहे. चालू कर ना आता, तिकडे चालू झालाय. यांना चालू करायचं आहे. सर इंग्लिश हरने वाले को बोल दो खाना खाने को. इंग्लिश हरने वाले को बोल दो खाना खाने को.
हॅलो. हे येत आहे का तिकडे? हे डिस्प्ले होत आहे.
चालू आहे ना.
एक काम करा ना, हे हां ते एका साईडला चालू राहू द्या ना, तोपर्यंत मी हे दाखवतो ना. नाही आता पहा मॉडरेटर मी राहील, ठीक आहे. कनकराय सरांना ठेवू आपण. हां धारप सर आहेत, शिशिर सर आले आहेत, त्यांना ठेवूया, ठीक आहे. ये प्रोजेक्ट कर पाएंगे उधर? हाँ आला का? आलं का? चेंज करायला कोणी आहे? क्विजसाठी आता काहीच नाही. Sir, we are having some 5 to 10 minutes to start with because they are inducing the case. Till that time, if the forum permits, we can have a 5-minute small discussion about difficult laparoscopic cholecystectomies. Shall we or shall we not?
Yeah. Enough people here.
Yeah. हे पुढे मागे करायसाठी आहे. ग्रीननी पुढे होईल. So sir, difficult laparoscopic cholecystectomies, actually if you see the title, the difficulty arises with the amount of the experience that the operating surgeon has. The difficulty also arises with the amount of difficulty you have with the anatomy. And most of the times, it is between these struggles that we find it out that we have landed into soup, and then we call up for senior help. So this is one of the most loved pictures by all the young surgical graduates who will be wanting to see a very safe laparoscopic cholecystectomy. So what amounts to a difficult laparoscopic cholecystectomy? So dense fibrotic adhesions in and around the calyx. A gangrenous gallbladder can also present like a very difficult gallbladder. Empyema GB, impacted stone in the gallbladder neck. A relatively contracted GB wherein you cannot actually have space to even hold the gallbladder. Mereses, history of biliary pancreatitis, CBD stones, acute cholecystitis more than 72 hours. So what is easy and what is difficult? So these are certain criteria: time taken more than 60 minutes, no bile spillage, no injury to the duct as we have seen in the morning. Difficulty, time taken more than 60 minutes, bile spillage, injury to duct, or there is some amount of conversion, should be no conversion. Very difficult, time taken more than 120 minutes. So these are certain listed things: that male, sex, advanced age, prolonged history of gallstones, systemic signs of sepsis, and USG findings of wall thickness more than 4 mm, porcelain GB or GB calcification. Sir, anything you want to add into this? Hello.
A history of choledocholithiasis and previous stenting. So that leads to a lot of adhesions and problem because of that. Previous surgery.
Previous surgeries, yes.
Pericholecystic collection, that is also
yes,
indicator, one of the indicators. Thick wall gallbladder, contracted gallbladder, pericholecystic collection.
Yeah. Cirrhosis.
Gallstone pancreatitis. Means CBD stenting has been done. So these are.
So that is why we arrived for the Tokyo guidelines, and they have divided into mild, moderate, and severe. Some anatomical variations of utmost importance that everyone should be knowing as to why and where we are getting this. CBD injuries and how to avoid them, thorough knowledge of the relevant anatomy. It underlies for any surgical procedure that we are going to do. Understanding of the mechanisms involved in the biliary and the vascular injuries. And that is like कि नहीं शायद injure नहीं हुआ है. That is the most first thought that strikes the surgeon mind, नहीं हुआ है. And then eventually when it happens, the bile comes out in the drain, and if at all there is no drain, then probably through the site it starts coming. Identification of various pre-op and intra-op predictors of difficult cholecystectomy. More amount of time is required. Probably larger number of clips are required. Larger size clips are also required. Proper gallbladder retraction, most of the times it may not be possible to retract the gallbladder because of the liver conditions, or there may be adhesions between the anterior abdominal wall and the liver that does not allow us for the retraction of the liver. Energy devices, yes, with the advancement, energy devices are making our lives simple, but understanding as to what is to be used where is of paramount importance when we are using energy devices. Understanding the critical view of safety. I know Darvi sir talking at least half an hour for the critical view of safety whenever he is talking about a safe lap cholecystectomy, and that itself is a testimony as to why a critical view of safety has to be shown when we are doing a laparoscopic cholecystectomy. Fundus first. Now it has been said that awareness about various error or traps like fundus first technique. So I am aware that certain medical colleges, there are certain professors who are also teaching that you should be able to do a fundus first in a normal patient first rather than doing a fundus first in a difficult case, because in a difficult case doing fundus first may land up into very many difficulties as compared to a fundus first you have not done in a normal cholecystectomy. So bailouts, again bailouts is something that every laparoscopic surgeon has to understand, because bailout actually gives time for the patient and for the surgeon also to go back and see what has happened and then come back to the patient with answers to what has happened and then give a remedy to what the patient can have. Understanding the concept of timeout also. So in our hospital 2022 there were only 22 difficult lap choles that we have done. 23 we have done 11, and 24 it's 48. So this is a 78 years old female, diabetic hypertension, hypothyroidism, generalized weakness, mild pain, abdomen since 3 days. USG suggestive of periacalculous cholecystitis. CCT abdomen was done, acute calculous cholecystitis with contained perforation was shown in the CT scan. Patient was planned for lap SOS open cholecystectomy, but patient was not given clearance for surgery as patient also had an IVC thrombus. Now the big question. Patient preferred to go to higher center where they also managed conservatively. Patient came back to us, repeat CT done, mild changes of cholecystitis, resolving collection, planned for a lap call, and PAC fitness was done with a DOT consent. पहला वाला वीडियो कहाँ है? Is it playing or not? तोपर्यंत ओटीला विचारा ना, रेडी झालाय का? इंड्यूस हो गया? हां. So as you can see, the whole of the omentum is hugging the anterior abdominal wall. This is my optical port and I am trying to see कि अब मैं कहाँ पे जाऊँ. So I am using my camera only, my telescope only to see. Now you can see the whole contained perforation inside.
Hello, check. Hello. Hello, check. Hello, check.
Almost a liter of contamination which was contained in the whole space. Now somewhere a sigh of relief that I am able to see the liver. Forward थोड़ा कर.
आप मेरा मोबाइल संभाल पाओगे?
I guess the OT is ready there.
ये दोनों आपके पास ही रखो.
After having some space to introduce my epigastric trocar, I am just using the blunt instrument.
हे काढा, फिक्स नका करू, हे काढा. नाही नाही, आधी हे काढू ना आपण, ते चेंज करायचं आहे पोझिशन म्हणून.
See, the perforation is at the fundus. You can still see the bile which is coming out. I was not finding any space posteriorly. There was some vessel which was there. I was not able to identify. I clipped that vessel. I kept on seeing for the for the cystic duct. Now somewhere I could get some space. The stones were also, they were also getting down.
हे पण टाईट करा माझ्या हाताच्या खाली. ठीक है, इतना है, एक मिनट स्टेप लगा दो. हाँ फिक्स फिक्स फिक्स.
थोड़ा फास्ट फॉरवर्ड करो.
ये आपका आईवी सेट थोड़ा सा, आईवी स्टैंड थोड़ा हट सकता है. ये मॉनिटर थोड़ा यहाँ पे आ जाएगा.
So here I could identify the cystic artery and the cystic duct. You could see that the cystic duct is already taken up. As Dharab sir usually used to say that it is easier to do a lap cholecystectomy when it is inflamed because the planes will open up themselves. But here it was tad bit difficult because the patient was conserved for more than 3 weeks and she had pain and fever, which was the presenting complaint. Sir, any comments regarding this, sir?
I would consider using a monopolar, not an instrument of choice. You either use a bipolar or you use a harmonic, because monopolar can cause damage which can be bad.
Point well taken, sir.
बस बस, enough.
This gallbladder was later on retrieved in a bag. Thorough wash was given. All the contamination which was present everywhere.
We'll need one more person to wash this.
Sir, it was suction. Yeah, it was the suction tube.
Should I ask sister to detect?
Yeah, yeah, yeah.
So in thoracic surgery, we have a very beautiful, we call it as the peanut, but it's a metal peanut. So it helps us to peel from the lung. So if you have an empyema when you're doing a VATS, it's a long VATS instrument, but it can go through your 5 mm. So think of it. It's a very sasta machine, but it's a very good thing in such because it gives you the effect of peeling, like, huh? No. So it's actually a metal peanut. We use it for a lung thoracic VATS quite a bit. But you know, when you have such things, it may help you in dissecting. That's what I felt.
Yeah, we'll just take it. We'll check whether the patient is slipping or not.
It's a blunt metal.
Table up.
Peanut, metal blunt peanut.
So basically, sir is talking about a laparoscopic peanut, if we say it that way. Yeah.
But it's metal.
Yeah, Dr. Sudat.
This will be the position. Okay?
Was the patient stented before?
Stab kar lo.
Is it important to do a CBD stenting if you are anticipating a difficult gallbladder?
I think per se for every difficult gallbladder, we should not be stenting it. I think that, I mean, where your suspicion lies that you have to deal with a cholecystectomy, you do an MRCP. MRCP doesn't suggest for any stone. Don't go for a CBD stent because it is not required. What is the opinion from the August gap?
Harmonic hand switch नहीं है क्या?
No, I think I agree with you. What I think Sudat wanted to say is like for a difficult, say, rectal malignancy, we will go for DJ stenting of ureters. Similar to that, whether you do DJ means biliary stenting for difficult gallbladder. So we don't do generally. We don't do.
Chalo. Scrub.
If you're doing a revision cholecystectomy for some cholecystitis, they do it because first time it must be difficult. No?
Stump cholecystectomy.
So for if what sir is saying is if we are dealing with a patient who has undergone a cholecystectomy but now is presented with a stump cholecystitis sort of a thing, then probably going ahead with a stenting may be usually helpful. Are we having time? नीचे चालू हुआ है? Pain चल रहा है. In the second case, he is a 42-year-old patient, known case of hypertension, pain in abdomen since 1 week, fever present since 2 days, abdomen suggestive of a perforated GB with a 10 into 12 centimeters of hepatic collection. She's a female patient. Planned for emergency lap cholecystectomy, and it was done on 3rd of February 2025. Perforated gallbladder with dense omental adhesions with hepatic collection present. Video, please. So again the same thing. The whole thing is up. This 3 lap polycer I did in the morning of Monday.
Date is 3rd February.
Yeah. So with this blunt instrument, I am just trying to move away whatever is there.
So this is like lap peanut.
Yeah. Yeah. Sir, what to do if there are, what to do if there is, the disease is advanced and the adhesions may not come out like this? Cholecystostomy and come out. So again, you can see that so here it looks like there are 2 falciforms or what?
See, now what has happened is, with the increasing expertise in lap chole, if the cholecystectomy is difficult laparoscopically, then open also it is going to be difficult. So then better to go for cholecystostomy.
साधा गाउन आहे का? साधा गाउन आहे? साधा गाउन. हे नको.
नहीं, इसमें तो पूरा collection ही था मैडम. Actually, this patient I remember we had sent for a USG, so they said that there is a lot of collection around the liver. Looks like there is a liver abscess which has ruptured. So they aspirated around a liter of thing. And again, when I was doing this, I also aspirated somewhere around 600 or 700 ml of pus.
7.5.
See, in the both cases, it seems it's very difficult, but it depends on the location of perforation and omental adhesion. So I think callot was not that much difficult as compared to as is the perforation in the fundus. So after separating the omentum, we could dissect it better. But when there is a dense adhesion or frozen callots, cholecystectomy or partial cholecystectomy is always an option. The approach can be either laparoscopic or open, depending upon the expertise.
Okay, sir. But mostly in your practice, sir, the perforation, whatever you must have had seen, were they more of fundic perforations somewhere down?
Fundis are common, very common. Fundus is very common.
I think it's a very good practice to see the CVS before you do any ligation. So if you dissect little more on the medial side, you'll see a CVS, and if you rotate the thing and see the anterior side, and CVS has to be seen till not the end of cystic duct, but lower end of gallbladder should also be exposed. That will help. 1/3, layer 1/3, and then you will not go wrong. Lateral. So that would be a good practice to just see the CVS before you ligate anything. As Dr. Srikhandi used to say, every surgeon has either cut a CVD or injured a CVD or will injured. So if you take that will injured, then always will be careful.
हाँ इधर ही रुकेंगे. एक बंदा इधर होगा, एक बंदा इधर होगा. आपको कैमरा उधर से लाना पड़ेगा शायद. आलो क्यों दे रहे हो?
हाँ. हाँ ready है ना? चलो. So now we are going to the OT. Third case.
I will just interrupt you here, Harshvardhan. On behalf of President Mumbai Surgical Society, Dr. Shishir Shetty, I call to order the AGM, which is scheduled at 2 p.m., but adjourn it due to lack of quorum, and we will reconvene in 15-20 minutes in the dining hall. This is for the members of Mumbai Surgical Society. The transmission will go on, the live workshop will go on. We will join you as soon as we finish our AGM. Thank you.
So this patient we received from Nasik. He was a 44 years old male, known case of diabetes and hypertension, pain in abdomen since 4 days, suggestive of a perforated GB with acute cholecystitis. USG guided pigtailing was done at outside hospital in Nasik. Referred to our hospital for management and workup for lap cholecystectomy. It was again done on 3rd. So please.
फोटो लेके ट्रांसमिट कर दो.
So this pigtail was there, which was in the fundus.
ये हो गया, फोर्थ पोजीशन बता दिया.
The momentum could come down easily. Sir? No, pigtail was not clamped. नहीं वो तो अंदर था सर. नहीं मैंने वो इसलिए नहीं निकाला बिकॉज न्यूमो बाहर जा रहा था. हाँ तो बाहर से क्लैम्प कर लिया. So I had clamped the pigtail from हाँ yeah.
समझ में नहीं आता था, और आधी रात को तो बिल्कुल समझ में नहीं आता था. By what? The skills, sir. What nonsense. Seriously. I should tell my wife. Someone is impressed. Calculate 14 centimeter, it comes somewhere here. Yes, sir. Today we are lucky that it's come right on the upper. It should be 14 centimeters. Right on the zip. That's how you mark. Otherwise, you either go very high up or you go very low down. I always put the post using this right hand. The safety is max. आपका 10 mm दो, ये दिखने में अच्छा नहीं दिखेगा. शार्प नहीं चाहिए, ब्लंट तो दे दो. मेरा टोका डाल देना. मैम इंसफ्लेटिंग प्रेशर कितना रखना है? लो ये 10 है सर, अभी 13. प्रेशर 14 करो. कैमरा डालो अंदर.
There was some difficulty while taking the gallbladder from. Hello sir. There was slight difficulty while taking the gallbladder out from the GB fossa.
यहाँ पे वो नैथिसन लगाओ, थॉमसन लगाओ. यहाँ पे थॉमसन का रॉड लगाओ.
नहीं ते राजेश
आप कैमरा के लिए क्या लेते हो? गर्म पानी लेते हो या बिटाडिन सलाइन लेते हो? गर्म पानी लेते हो. अभी तो नहीं चाहिए, अभी तो बढ़िया दिख रहा है.
That is it. Now we can shift to OT number 2. Dr. Hemant sir, can you hear me?
Good evening.
Hemant sir?
Hi, am I audible?
Yes sir, you are audible. Am I audible to you?
Put in the, yeah, hi, you are audible. We have just put in the supraumbilical camera port. And now we are setting up the Thomson retractor for having the Nathanson in place. We have marked the ports. Could you see the markings of the ports?
To chair this session, I would request Dr. Kishore Jain is here. नहीं.
अपने आप लगा दो ये लो.
Dr. Pavan Khandelwal from our Central Railway Hospital, Bhusawal. Dr. Rajesh Yadav, sir, ex-president MSS. Sir, please. Yeah. अच्छा. हाँ थोड़ी देर के लिए. Anybody from the OT can you give us a brief of the patient?
दोनों आपके फायरमैन दो सिस्टर.
So basically, I know this patient. He was admitted under me. He is a young chap, around 35 years of age, and having complaints since last 3 to 5 years that he is having this intermittent vomiting. Whenever he has food, he will swallow the food, and after some time, he is having vomiting. So he underwent ojidoscopy. He underwent a trial of first PPI. He was not happy with that PPI treatment. Then he underwent an endoscopy. Endoscopy was suggestive of a hiatus hernia with some amount of esophagitis. Later on, his उसका ये है क्या अपने पास? Manometry का picture. Manometry was done, which was again suggestive of a huge hiatus hernia. So Hemant sir.
Yes.
Sir, kindly guide us with your ports.
So, just a second. Yes, I have taken the camera port in the midline above the umbilicus. Basically, I calculated 14 centimeter from the Zephyr-sternum for my camera port. My two working ports are subcostal in the right and left midclavicular line. This is the point where we will be putting the Nathanson. Nathanson is at the Zephyr-sternum. We are using the Thomson's and we'll be having one lateral port on the right side, lateral to the camera port, for the assistant to detect the fundus.
Sir, your idea for anybody who is not having a Thomson's retractor and still wants to do a fundoplication?
Of course you can do. Take a port on the right side, have a Alice forceps, hold the left crus of the diaphragm or lift the left lobe of liver. Everyone doesn't have a Thomson.
Yeah.
So, I am not using that port right now, but if you see this port, instead of this port, have a port on the right side, right anti-axial line. From there, you go down, you lift the left lobe of liver and catch it here. So you get a very good detection. See, I can see the J junction right now.
Yes,
That's
yes.
how you do if you don't have a Nathanson. Nathanson is a luxury. Everyone of us don't have that. While putting the Nathanson, initially I made some space for myself. We have to be very careful of the curvature of Nathanson, otherwise it can cause injuries also inside. retract the left lobe of liver. Show me here. Show me. And we have to ensure that the retraction is adequate before we fix it. That will help me out. I'm holding this.
Yes, Thompson itself, they have port holders or a camera holder if you want to figure it out.
Yes, yes, yes.
If you can see the assembly outside, you will get an idea of what we have done. We have a rod of the Thomson retractor and we have the further assembly of the Nathanson retractor. That's how we have mobilized. When I went to buy this Nathanson retractor, I had got a quote initially of bipolar 1.3 lakhs. But my final Nathanson costed me around 40,000 rupees because I did not buy this rod. This rod was already there with me. Can I have a sheet of cloth? कब तक जा सकते हैं यहाँ पे? बाइपोलर कितने पे है? Am I audible?
Yes, yes, sir. You're audible.
This is the fundus. This is the pars flaccida. पूरा खोलते हैं और इसके ऊपर बाइपोलर लाइट सोर्स का केबल थोड़ा स्लो करिए गुड ओके इज द विजन गुड
Yes, yes.
so this is the caudate lobe behind, this is the left lobe which is retracted, the fundus of the stomach. The spleen you see out here, somewhere here will be the short gastrics, and this is the pars flaccida. We'll start by incising the pars flaccida. We'll go on to the right crust, start the dissection, cross the G junction, take the peritoneal cut on this side, and then dissect further. Okay? ऊपर का लाइट बंद करो.
On है, on है.
Hello, sir.
Yeah, tell me.
Can you please do the white balance for the telescope, sir?
It's usually the other way around. The vision in the OT is better, vision in the audience is not very good. I think right now it's reverse. We are seeing it very well. White balance, yes, good. वापस कर दो. I have frankly not put in the fifth port yet. If required for detection, I'll put in. Otherwise, I'll manage with 4 ports only. When we do this step, at times we can have the left branch of the hepatic artery come in, or even the exercise left gastric artery can come in. Come closer. Go closer. Yeah.
Meeting है हम लोग का. Sir, you will be coming back. आले पे निघाले.
नाही तो 7 रस्त्याला पोहोचला तो मला फोन केला त्यांनी. त्याला वाटत असेल की मी इथे आहे तर त्याचे केस ओढून टाकतो.
नाही सर असं का
This is the J junction and the stomach.
नहीं, I have already sent a गाड़ी and आकाश. आपकी गाड़ी गई, वो ये गया क्या? प्रीतम गया ना? प्रीतम का नंबर है सर के पास? आपने सर को भेज दिया सर? ओके बोला है ना सर? हाँ ठीक है. कहाँ है? बताने का ना. आकाश जल्दी देख सर, नीचे ओटी में गए. निरंजन अग्रवाल. हाँ. हाँ ये भी कर सकते हैं. So till the time the MSS team is there, I would request Dr. Sujit, Dr. Ashish, and Dr. Shubham to join for the panelist. Please come.
You see behind here is the esophagus.
Yes, sir.
अभी तो काम नहीं है डॉक्टर साहब आपके लिए.
Hello, Hemant. Dr. Nitin here.
Hi, tell me.
Hi. What is your extent upper limit from the right
We should
crus?
have a mobilization of up to 5 cm intra-abdominal length. Max we can go is up to the inferior pulmonary vein, but usually that much is not required. So here I am entering the mediastinum.
Yeah, I could see that. How do you prevent the pleural opening here? What
Sorry?
precaution? How do you prevent pleural opening while mobilizing the 5 cm
When you are
intrathoracic
here,
cyst? Huh?
you don't cut, you just push.
Okay.
Put in one more point. Give me 5 minutes. If in the mediastinum you come across any hard structure, that's usually the pleura. So you have to just push and do minimum of cutting. And in case the anesthetist feels that the CO2 is increasing, patient is developing hypotension or something, then you have to suspect a opening in the pleura. And the best way to treat is to make that opening even larger.
Okay.
Come here, doctor. What's your name? Come. Saurabh.
So you are putting fifth port for
Sorry,
fundus?
yeah, I put in one more port.
Yeah, it is.
For retraction. Making my life comfortable.
Yes, I agree.
Yeah, hold this.
Case induced हो गया.
So now our assistant surgeon is giving a traction, making the GI taut. So we can use both the hands to push inside the mediastinum. have to be careful of the vagus nerve out here and also the pleura. Vagus has to be approximated to the esophagus. The wrap goes behind the vagus. Stemcy tissue, that is all the mediastinal tissue.
राउटी बोले तो ये वाला I think that is a vagus.
Yeah.
I could see that.
That's the vagus.
Yeah.
Excuse me, sir. Sir, we have the last and final case also being induced. So it's in OT2. It's a complex fistula in ANO, and it's being done by Dr. Niranjan Agarwal. OT2. Am I audible? Hello. Unka.
Hello. Yes, Darshan, you are audible. Am I audible?
Yeah. You may begin. You may please present the case.
Yeah. So this is a 28-year female with no known comorbidities. Came with chief complaints of recurrent painful swelling in perineal region and perianal discharge on and off since 3 years. She had a history of multiple perineal abscess IND in the past. Her recent MRI fistulogram suggests of 2 partly fibrous tracts with external opening to the left of midline in intergluteal cleft extending in left paramedian soft tissue and merging with each other with suspicious transsphincteric communication with another left intersphincteric tract with multiple focal collections, suggestive of grade 4 perianal fistula. She was worked up for perianal fistectomy.
Dr. Niranjan Agarwal, am I audible to you? Hello. Dr. Niranjan, sir, am I audible to you?
You are audible.
Yeah. Are you inducing? Is the case already induced or are you already starting?
Yeah, the case is induced. We'll begin shortly.
Okay,
Just a second.
Okay. Dr. Hemant, sir, am I audible to you?
Yeah, tell me.
Yeah, so you may please go on speaking about the case.
We are doing the right postulateral and anterior dissection from the right side. This is the mediastinum. The heart is anterior. The pleura has been swept aside, and the vagus we could visualize here. This is the vagus now, the posterior vagus now, which has been preserved. For now, this much will suffice on this side. And clear up this area a bit more. Throughout the dissection, the right crus is my guide.
So now you will go to the posterior side also, or you will finish the left side dissection first?
I will try posterior, but I have not mobilized the fundus yet. So if I am able to easily do it, I will do it. Otherwise, I will come back after I mobilize the fundus. Okay. After I open up the gastrocolic. This is the left crus which is coming in. You see, this is the left crus.
Yeah.
So to mobilize further, we will have to go in this plane. That will come from this side.
I think rails too we can see. I think you may have to remove a bit. So where do you start mobilizing the gastrocolic?
Not this point.
Not.
This is not the start of mobilization. It was visible quite evidently, so I am just taking it down. Otherwise, you start on the greater curvature. Come back.
How do you decide where to start?
So we usually start at the midpoint of the body. This is the fundus. Okay, so we'll start somewhere here, which is the midpoint. From here, we'll disconnect the stomach from the omentum, and then we'll proceed. Can you hold this? Clamp it, please. You want me to use the ligature or thermonic? Whatever you have. What do you have? Yeah, give the head.
So do you use always 5 port, or you can able to complete with the 4 port also?
Sorry?
Do you always use a 5 port?
No.
You
Many times I do a single incision.
Okay.
So it's a 2-port then. I have a many times I have a single incision at the umbilicus. I have 3 ports coming in from there, and I have a single incision at the Ziffy for the Nathan.
Okay.
I've done about 3 single incision lab fundoplications till date. But I was not comfortable doing that as a demo.
What energy source you are using here?
Right now I was using Lagashwa, but I am shifting back to my workhorse instrument, the bipolar sealer cutter. Lagashwa is an excellent instrument, no doubt about it. Come closer. Smoke निकालो. When we mobilize the fundus, we have to be careful that we mobilize it properly in the posterior plane also. Many times the mistake we do is we mobilize the greater curvature, but we don't mobilize it posteriorly very well. You can advance your instrument. Just leave it like that.
While mobilizing the greater curvature, have you come across any time there is an adhesion between the posterior part of stomach and pancreas?
At times you do have significant adhesions. You have to patiently dissect them out.
Between stomach and pancreas, I am asking.
Yeah, between stomach and pancreas. Hold this. Lagashwa to me. I think either you need a hot water, you need betadine saline. The camera is fogging.
I think please clean the camera.
Please give me some dynamic retraction. You can see the short gastrics pulsating very well in the distance.
Yes. So, what are you planning, Nissan or Tupe? What is your take on both?
So this is a young chap, and on manometry, his esophageal body function is good. The peristalsis is good. So we are planning a Nissan. Tomorrow I posted a surgery. She is a 78 years old female patient. For her, I am planning a Tupe. Basically, if the body function is not good or the patient is old, I personally have a preference for Tupe. But in a young patient, I always prefer a Nissan. Short term, the outcomes are equal for both of them. It's not that one is superior over the other on the short term. In the long term, Nissans will score over Tupe. But if there is even a slight doubt that the patient may land up in dysphagia, better to do a Tupe than do a Nissan. Today we have a luxury of lot of space between the stomach and spleen. Many times
we could
that's
see
not
that.
the case.
Everyone could agree.
So in case it's very close by, I would rather go on the stomach than go on the spleen.
what is the manometry finding which will absolutely contraindicate you from doing any fundoplication or any sort?
Absolutely contraindicate.
Yes. Is there any contraindication for fundoplication from in the
The
manometry?
esophageal body function is very poor.
Hmm.
Then I will not do a fundoplication. Why should I give the patient dysphagia?
For the sake of PGs, I am asking you.
So if the esophageal body function, the peristalsis is very poor, making a high pressure valve at the lower esophageal sphincter, which will actually make the life worse for the patient. The patient will not have reflux, but the patient will end up in really bad dysphagia. That is one place where I will not do a fundoplication. Or maybe that's a place where you can do a repair like a Hill repair. Just restore the G junction. Not to pay, not listen. A Hill repair would work better in that case.
Okay.
What do you think?
Yeah, I do agree.
So we are slowly taking the greater curvature of the spleen, we are ligating the short gastrics. On purpose, I am coagulating it twice and then cutting in between, just to be extra sure. Despite all this, we can have bleeding. Just an added layer of security for us. Ensure that your retraction works for me, man. Okay, hold it lightly. You are holding vessels in this. Yeah.
Just a second, sir. Dr. Niranjan, sir, am I audible to you?
Yeah,
very much audible.
Yeah, sir.
Who's on the other side?
Tell me.
Who's moderating?
Hello.
Good afternoon, everyone.
Hello.
Good afternoon, sir.
So, you got the history of this patient, right?
Yes, sir. Sir, can we have a look on MRI of this patient, sir?
Patient's MRI is to be shown. Camera उधर focus करो, please. उधर दिखा दो. So according to the MRI, there are two external openings which are not there here. There are only scar tissues here.
Yes, sir.
Can you see this?
Yes, sir.
अच्छा उधर. Somebody has read out the report?
MRI is too far from the camera, sir.
Anyway.
Not visible properly.
Do you have a radiologist in the hall to read it out to you?
No, sir.
Okay.
Sir, we are expecting some discussion from you on MRI. How does it help you from that? Dr. Nitin here, sir, from Nair Hospital, Nitin Borle.
Yeah. So, if your MRI is not reported by a very sensible radiologist, then it helps me only in a way that I get the reference for that patient. Because they report it in such a way that people get scared and they send the patient. So that is what I get help you are asking me. Otherwise, if there are radiologists who are very particular, they will report from the internal opening that the infection starts from here and then there is a track which goes into the intersphincteric space, traverses either right, left, whatever it is, then pierces the external sphincter and then they divide into anterior, superior branches, etc., etc., etc. Now here, if I ask you somebody to read the MRI report, you will get equally confused as I do. You know. So what all I can gather is there are two tracks here at two positions which merge at the just inside the sphincter and form one track which is probably opening at 5 o'clock. But they have mentioned also that another track from 1 to 5 o'clock position. You get my point? which is not visible over here. There are no external opening, there are only scar. This patient has been operated 3 times for an abscess drainage. So what we have done, we have identified the internal opening which is somewhere around 5 o'clock position. We have tried to probe it, put methylene blue. Most of the methylene blue has come out. We have not been able to see the other end of the methylene blue anywhere. So what I am going to do right now is, one thing is sure that the pathology lies in the intersphincteric area at 5 o'clock position. So that is what I must excise. If these 2 tracts are already fibrous, then they really don't need much kind of a consideration. But once we go inside, we will come to know further about it. So I am going to start my dissection here. I have injected some adrenaline solution over there. If you don't get the internal opening and you inject adrenaline.
Am I audible?
Sorry?
Am I audible?
Yes, sir, you are audible.
So this is the anterior cut we had made previously, and we'll be joining the 2 cuts right now. That's the limit of our dissection. Come closer, please.
Niranjan sir?
Yes, sir.
Is there any clinical finding at 5 o'clock, sir?
You can see this puckering over here. You can also see the papilla there. Can you see this puckering here?
Yes, sir.
This is the dentate line. There is a puckering here with a papilla just over
Yes,
that.
small papilla is
So
there, sir.
that should make you suspect. Other thing is, if you inject saline adrenaline or even saline in the submucosal area, the whole of the submucosa get lifted except at the point of the internal opening.
Yes,
Can
sir.
you see this
Yes, sir.
pencil going inside?
Yes, sir. Dipping area.
So I have injected methylene blue from the internal opening, not the external opening. So right now what I am going to do is I am going to excise this. I am going to excise this internal opening.
We don't need that light. Please turn it off.
I think cautery is disturbing.
Take a light nature.
Tooth posture.
Come closer.
थोड़ा टेबल नीचे लो प्लीज, नीचे लो प्लीज. या ओके, लाइट वापस फोकस कर दो. टेबल हो गया नहीं? टेबल सक्शन लो, सक्शन ऑन करो. लाइट एडजस्ट करो. सामने दिखना भी चाहिए ना. Suck and go. Suck and go. Can you see the internal sphincter fibers here?
Yes, sir.
The white color circular fibers, those are the internal sphincter.
Yes, sir.
Very generous here. What a very thin patient for me.
That's the methylene blue going there. Babcock. एक राइट एंगल लो छोटा, ये निकाल दो. जस्ट होल्ड इट. So the internal opening area is already avulsed with me. Show me a probe. This was the area where we sorted some methylene blue, but it is dry now. Can you see this?
Yes, sir.
So there is hardly anything more than this. Scoop. Nature has already taken care of the tract by fibrosing it, and the source, which is the internal opening, has been excised by
That's
us.
the other side that we see. So the posterior window is complete. We do the lateral mobilization and the posterior mobilization. Give me a Foley catheter. 10 French Foley.
एक पतला स्कूप दो, बारीक वाला स्कूप दो प्लीज.
आपने खोला था 10 French नहीं वो तो कोई भी दे दो. We'll take a Foley catheter to sling around the G junction so that we are able to give a more solid downward traction, and then we'll do the anterior, posterior and the left lateral mobilization. कोई भी Foley दे दो. 12, 14 कोई भी दे दो.
ये भी बड़ा है.
सिलिकॉन का नहीं, रबर का.
So there's no granulation tissue further than this, right?
Yes, sir.
Neither does the probe bore, nor am we able to scoop more than anything else.
हाँ दो. कोई बात नहीं दे दो. बहुत ही मोटा नहीं है.
So we'll just burn a little bit cavity which we saw that. Am I audible there?
Yes,
or?
sir. Yes, sir. You
Yes,
are
sir.
audible, sir.
So I don't think this patient requires anything more than this. Because rest of the tracts are fibrous, that's why there is no communication established. Even here we cannot see any further granulation tissues, and the source has been excised. This was the little tract which was going there. It is also stopping at a particular point, and we have already cauterized it.
Yes, sir.
So I will just marsupialize this wound and I leave it open to drain. That's all.
Okay, sir.
30 vehicle. So apparently, though it is looking very complex on the MRI or it is a recurrent 3 times, you can see that actually it is not so. You know, all that is required in this patient is excision of the internal opening.
Internal opening only.
I can't feel any more induration except this fibrosis over here. You can feel it. Right? Agree? 30 vehicle. जेली लगा दो. Is this vehicle? अदर वाइकल की क्या है ये? क्या है ये? क्या दिया तुमने? ये क्या दिया? No, this is PDS.